All right, well, welcome to week 9. It's almost over, 3 more weeks to go, right? Are we excited? Nervous? Don't know what to do yet. A little of all of the above, because HESIs are coming up. Yeah, I get it. I do. I pray for y'all. You're going to be fine. Just take a deep breath. You got this. You got it. You're so close. Just keep moving. 3 more weeks. Um, so we have a quiz today, and I will put the password in the chat. Everybody is on. All right. Real original password. It's 205 capital Q for quiz. Oh my gosh. 205 capital Q and quiz 5. So You guys did well on your last quiz. So that's awesome. Good job. All right, so I just putting out a reminder. Um, I did post it again just so you guys had it at the top of your announcements. But your exam 3 review sessions, there are, let's see, there's one tomorrow at 7 with Dr. Tenza. Then I have one on Wednesday at 10. Professor Bryant has one on Wednesday at 9 p.m. And then Dr. Morton Ford has one on Thursday at 6. And then Dr. Tenza's Kahoot is going to be Saturday morning at 8. So just like I said, I put it in your announcements so that it's, top of the announcements, not buried deep in your announcements. So please try to attend one. This way you get fully prepared for your exam 3, last exam before the HESI, right? So knock it out with a bang so we can, get everything straight and be good to go going into the HESI. Anybody have any questions on the quiz or anything else as of right now? Nope. All right, awesome. So again, it's week 9, so we're almost there. Moving forward, you still have your HESI practice exam, and then you have one last set of NCLEX questions due in week 11. So you got this. Just keep up the momentum. You guys are going to be fine. But for week 9, oops. All right, so for week 9, multitasking, we have chapter 15, which is healthcare settings, and then chapter 16. Let me just, give me one second. We got one more switching over. All right, so we have healthcare settings, and then we have the healthcare system, which is financing issues and trends. Anybody look at any of the information for this week? A little bit, kind of see what's going on with it at all. All right, so did we? Yeah, okay. I was just checking Faith. I'm like, did you get back in? Sorry, I had it scrolled it down because I was looking at attendance and I didn't see the waiting room. All right, so we'll start with chapter 15. I will go ahead and share my screen. All right, so chapter 15 is healthcare settings. And so with healthcare settings, we have both public and we have private organizations. So as so with public or with public agencies, their primary support is going to be taxpayers' money. They also, will do disease prevention, wellness promotions. In some cases, they will direct the service of healthcare and have, of course, accountability to taxpayers as well as the government. The programs are determined. There's mandated as well as non-mandated programs. With your private organizations, those are fee for service. And their primary service is going to be curing disease as well as illness. They also will do disease prevention as well as wellness promotion. And accountability is going to be towards the owners of the organization or the, what is it? The board of directors, right? And the programs are determined, by the goals of the organization. So this is just another breakdown of, you know, um, what it looks like. So has anybody ever looked into the difference between profit and nonprofit organizations to see what they would prefer to work with? No. And it really kind of just depends. And so when we look at, the local or the official government agencies locally, um, the official health agency at the local level is either the city or the county health department. And they are funded by local tax money as well. They get subsidies by both the city as well as the federal levels of government. They carry out the state laws concerning community health. They also carry out non-mandated programs like health promotion, and then they also work with other government agencies. They respond to community health issues like the outbreak of a contagious disease. Every state has a state health department and the official health agency that is also funded by state tax money. It sometimes will receive money from the federal government. So depending on where you are, is going to, determine, what, or I should say, whatever state is in, it's going to allocate those funds to the state health department. Has anybody ever been to their health department? No. Um, I spent a week at the health department during one of my programs. It was actually during my bachelor's program. It was actually pretty interesting just to see some of the services that they do provide. The official health agency is at the federal level. That is the U.S. Department of Health and Human Services. Um, and so Department of Health and Human Services has a variety of functions. It does have 11 operating divisions, including 8 agencies in the U.S. Public Health Services. It is funded by federal taxes. But some of the ones there are going to be like your U.S. Food and Drug Administration. So I'm sure everybody's heard of the FDA. That makes sure our food is good, our our medications for both humans and animals, biologic products, medical devices, electronic products that emit radiation, right? And just make sure that everything is, within code. If you remember pharmacology way back, whatever term that was, I don't even remember what term it is now. Was it term 2? I learned about, the FDA approval process for medications. It's very strict here in the United States, but we appreciate that, right? Even for food, making sure that our food is up to standards. Our process here is a lot different. It's a lot more stringent in the United States than it is in a lot of other countries, which is one of the reasons why we don't like import medications and things like that from other countries. Then, of course, we have the CDC, which is the Centers for Disease Control and Prevention. I'm sure everybody's heard of the CDC as well. That provides leadership in health prevention and promotion programs. They also respond to public health emergencies. The CDC is a wonderful reference tool if you're looking for disease processes, vaccine information. The CDC is a great website to go to as well. If you ever, when you graduate, plan on taking a trip out of the country, you can go to the CDC website. It'll tell you if there's any vaccinations or preventative or prophylactic medications you need to take, depending on where you plan on going. And then we have the National Institutes of Health, which is another one. The NIH funds biomedical research in its own labs, its own in universities, hospitals, private research institutions, as well as in the private industry. It also trains your researchers, promotes collecting and sharing of medical knowledge. There's 27 institutes and centers, including the National Institute of Nursing Research. There's also a bunch of other ones. There's the Health Resources and Services Administration. They improve access to medical care by strengthening the healthcare workforce. We have our substance abuse, what's it called? Substance Abuse and Mental Health Services Administration. Of course, that is to improve the quality and availability of prevention, treatment, rehabs for those like with addictive and mental disorders. We have AHRQ, which is the Agency for Healthcare Research and Quality. So if, looking at what, if you have, a question about current research, current practice, recommendations, things like that, AHRQ is a really good website as well. And then there's a variety of other ones that are going to fall under the Department of Health and Human Services. And then, of course, we have the World Health Organization, which is an agency of the United Nations that does a lot with, international public health. Your voluntary or non-official healthcare agencies, these are like your American Cancer Society, your American Diabetes Society, American Lung Association, the Heart Association, Alcohol Anonymous, La Leche League. There's a variety of those as well. Narcotics Anonymous. Trying to think if there's a whole bunch of other ones on there, but American Cancer Society, a lot of people have heard of the American Cancer Society. They do cancer research. They also provide information to clients as well as families and professionals. Of course, the American Diabetes Association is a really great resource for diabetic care and management, right? Patients can go on there. They can get information about nutrition, resources. There's educational programs, right, as a way to help manage their diabetes, even find like support groups, things like that. The American Lung Association, all about, about your lungs, your heart association is like research and education about heart disease, stroke. There's also the American Stroke Association, which is going to give you information on stroke. So Alcoholics Anonymous, Narcotics Anonymous, that's all rehab help and support. It's not just for the client or the patient, right? It's also for the family members to get resources as well. So there's a lot of different volunteer agencies available. Private healthcare agencies, these are probably the ones that you're more familiar with. There's proprietary or there's nonprofit. So proprietary agencies are for profit. And so they will charge a fee for their services, right? Generally, it's a payment system, whether it's your healthcare insurance or it is Medicare, Medicaid. Most people get healthcare through private providers, right? So if you don't qualify for Medicare, for Medicaid, right, most people will have some sort of private insurance, whether it's through the Affordable Care Act, through their employers, your spouse's employers, some cases your parents. Right, a lot of people just use private insurance as a way to pay for their healthcare services. Private healthcare. So when we look at private healthcare, family practice provides, primary care, and then they'll refer to specialists if additional evaluation is needed, right? So, let's say you have you hurt your leg and you go to your primary care provider, they may order some x-rays, some basic testing, right? But then they're going to send you to an orthopedist, right? So that specialist can look to see, you know, better evaluation of what's going on. What's nice about them, your primary care is like that gatekeeper, right? So if you think of people that have chronic diseases, so I'll just use diabetes as an example. So if I'm a diabetic, right, I have my primary care. I may also have an endocrinologist. I may have a podiatrist that I go to. I may have a cardiovascular doctor, right? A nephrologist. I may have a couple of different specialists, right, that I'm going to see. What's nice is that primary care is going to get all of those reports, and so that they can help coordinate care, for you as patient. Um, we also have private practice nurses, which are advanced practice nurses, who, counsel individuals on healthcare issues. So these are like your nurse practitioners, right? It used to be that, nurse practitioners couldn't work independently from a provider, right? But we know that rules and laws have changed. And now, nurse practitioners are able, I think it's with the minimum amount of time. I think it's like 5 years they have to work for a healthcare provider, and then they can break out on their own. I forget I'm not a nurse practitioner. So, but I think, they do. In some states, they don't. They can just, go off into practice, right? Especially thinking of those rural areas, right, where they may have limited providers, limited access to healthcare. If you remember back in community, right, you talked about those vulnerable populations. Can't even say the word today. So and then we have the different types of hospitals. And so community hospitals, those are non-federal, short-term general and specialty hospitals. Most of the community hospitals are short-term, but they still offer a diverse amount of, medical services. Um, the federal government, those are like your VA hospitals or Veterans Administration that are, or also in some areas you have state and county hospitals, or even, hospitals that are owned by the city. These are also like your mental health facilities, that are owned by the state. So your state psychiatric facilities. We also have things like teaching and research hospitals, critical access hospitals. So there's a variety of out there. Um, voluntary community hospitals. These are community associations or religious organizations that operate voluntary community hospitals. They're nonprofit. They provide short-term inpatient care. If somebody has an acute illness, or an injury, they are dependent on gifts and donations to supplement their source of income. So anybody know any religious organizations that operate voluntary hospitals? They're on TV all the time. I'll give you that hint.
Like St. Jude's.
St. Jude's or Shriners. Shriners Hospital is another one. I love Shriners Hospitals. Their commercials are so adorable. St. Jude's, they make me cry. Every time, especially when it gets to like that time of the year when they start doing their telethons and their radiothons and stuff. I worked for CHKD, which is a children's hospital. It's also think they're still nonprofit. I'm not 100% sure. Um, but they during their orientation, they actually play like one of the videos from one of their telephones. And I was crying in orientation. I was like, I don't know if I can work here. Like, I can't even make it through orientation without crying. Like, how am I supposed to work with sick kids? Um, but I did. It was just yeah, I don't know. But yeah, so you have those. And then of course your federal or state, that's your Veterans Administration. Talked about those. And then we have teaching and research hospitals. So community hospitals as well as federal government hospitals can be teaching and research hospitals. So anybody know a good teaching hospital?
I know where I'm from in California, Loma Linda University is a teaching hospital. So
Okay.
The
Yeah.
University of
John
Chicago,
Hopkins.
Centera.
Johns Hopkins, yep, Chicago, Boston University is a teaching hospital, right? So a lot of your hospitals may, Centera, Norfolk Gen, is right in obviously it's in Norfolk, Virginia, but it's got like Eastern Virginia Medical School is right there associated with it. It's all on the same campus, right? So these hospitals are great for, training sites for healthcare professionals, not just providers. So not just doctors, but also for nurses, um, and other healthcare professionals. They will still treat clients. I mean, that they're still a hospital, but they also complete research. They, look to develop different treatments for disease conditions, health promotion, and then all while trying to deliver low cost, high quality care. Again, these are usually always affiliated with medical schools. And they're, providers they usually will have access to pretty highly skilled practitioners. Um, Critical access hospitals. And so they have no more than 25 inpatient beds. The average length of stay is no more than 96 hours. Um, for acute inpatient care. They're more located in the rural areas, at least a 35-mile drive away from any other hospital, right? So think about that's a really small hospital, right? Only 25 beds. And so it can provide care for common conditions. They can provide outpatient care. And then of course, if there's, a really complex condition or something more serious, then they can refer them, those clients or those patients to a larger healthcare system, right? But it's a rural area. So, right, in some cases, think about we may have to find ways to transfer them, right? How do we get them from the small rural hospital to a larger hospital 35 miles away, more than 35 miles away? Ambulatory services, those are private as well as public as well. So these are things like your outpatient hospitals, your nursing care centers, your HMOs, your community health clinics. Generally, these are, going to be a little bit less expensive. And, these are people that are ambulant or that live independently. They're cared for at home. Um, and so this can be like your healthcare provider's office, in some cases, a freestanding ambulatory center, urgent cares. I'm trying to think. Nursing care centers. Oh, I said that. But then, your community health centers, their Indian Health Service would fall under this as well. But outpatient clinics, there's a variety of these in any city. They can manage disease on an ambulatory basis, right? As long as that patient doesn't need to be hospitalized. It can also provide the follow-up care after somebody's been discharged from the hospital. They sometimes are, part of a health care facility, or they can be freestanding, right? So, if you go to a hospital, some of the especially some of the bigger hospitals now, right? You have the hospital, which, the inpatient part, right? And then they may have like a medical arts building or another, annex to that, where they have providers' offices, right? They have specialist offices and other things. Um, Generally speaking, you will need an appointment to be seen. Um, and, it does include your specialties. And then, of course, how many specialties is going to depend on the population of the medical needs of the population. And so really kind of just depends on where you're at and what the healthcare needs are. In some of your more, your larger cities or your larger areas, they obviously are going to offer more services, whereas your smaller cities and towns, your rural areas may not have the same amount of specialties that are offered, right? Just because of location. Urgent cares, and there's, you know, um, these are for walk-in, right? You have an issue. And so for a lot of people, people use urgent care more as a primary care than they do actually in urgent care centers. Um, but the urgent care centers, they do make primary health care available as an alternative to a, family practice provider. It's also a little bit cheaper than if you were to go to the emergency room. Um, it's also a little sometimes more convenient, right? If you work during the day and you can't get off in order to go to see your primary care provider, right? You may use one of these urgent care centers because of the availability of the after hours. Um, and so there's a variety. One thing that was really interesting to me, and when I came from Virginia down here, in a 1 mile, like just around this area, there's like 6 urgent cares. I mean, it's crazy. They're like in strip malls, like, and I'm just like, I mean, I'm, used to seeing urgent care centers, but like they're everywhere here. And I was like, wow, it must be, and there's an abundance of healthcare providers too. Now, I don't know like how easy it is for people to get in to find a primary care provider here. But there's, like I said, there's urgent cares and freestanding emergency rooms all over the place. And what's really interesting to me too is there's billboards that will tell you what the wait time is. Like, so if you're like driving down the interstate, there's can't remember the name of the hospital, but there's a hospital that advertises its emergency room, and it actually has the wait time listed on the billboard. And I haven't seen it go over like 15 minutes. So I thought that was really interesting. Good to know, I guess, if I needed to go to the emergency room, but it's just it's just, there's so many down here. Um, I just thought it was really interesting to see that. Um, but these are, convenience clinics, they're express care, quick care, urgent care. It's a variety of different names that you're going to see. We also have 1-day surgical centers or your ambulatory surgery centers, which these are pretty cool as well. It's not a walk-in, right? You still you're gonna have a scheduled surgery. And so, you go in the morning, you get checked in, right? They do your pre-op, you have your surgery, and then once the patient or the client is recovered from anesthesia and they're considered stable, right, then they get discharged home. And so they eliminate the need and monetary charge for being hospitalized overnight, which can be very, very expensive. Um, and so there's freestanding outpatient surgery centers, or there's actually surgery or like same day surgery centers that are located within the hospitals as well. Most surgeries can be performed in a ambulatory surgery center. They are not going to do like complex surgeries. So these are more of your minor, not that any surgery is easy, but Let's put you're not going to have an open heart surgery or a cabbage in an ambulatory surgery center, right? This may be like, um, a tonsillectomy. It may be like a knee replacement, a hip replacement, right? Something where we can discharge you home that same day. Um, and then free clinics. And so free clinics are those that are either free or they are reduced fee. Um, and so they are an alternative means of providing primary health care for those that can't afford traditional healthcare services, or they're more reluctant, um, and then cost is based off of their income. So obviously, if you have a higher income, you're going to have a higher cost. They usually are staffed with volunteer providers, both, doctors, nurse practitioners, as well as nurses. And then they have a volunteer board that makes the policy decisions for the clinic. And so free clinics are really good, especially for our homeless population, right? That they can access, if they have them available in the area. Um, and then we have our skilled nursing care. So skilled nursing care, these are long-term care facilities, designed to help people with disabilities or chronic medical needs. Um, Skilled care is considered care that is medically necessary to improve the quality, of the client's health, or to maintain or slow decompensation of a client's condition. So what are some services that we offer within a skilled nursing facility? I know I asked a question.
Occupational therapy, physical therapy, speech therapy.
Yeah, we're going to offer your speech, your occupational, your physical. What else are we going to offer?
Nursing. I mean,
Nursing.
and
Right, your nursing care, right? So if they need IV, if they, have a PIC line, they have a central line, they need wound care, they need any kind of monitoring, the medications, right? So, whatever the services are that they require. And usually with skilled nursing, it's usually transitional, right? They'll go into a skilled nursing facility. And there's a couple of different options that can go with a skill with, that, they can stay in the skilled nursing facility. Again, it's usually short term. Um, Medicare will pay, I think it's up to 90 days for skilled services, sometimes longer, depending on the need. Right now, the average stay is about 30 days in a skilled facility, so it has dropped. Um, but, and then a lot of times they are discharged to home, right? They may get some home health care once they're discharged home. Otherwise, in some cases, they may transition from skilled into a long-term bed, depending on what the needs are of, the patient. Um, and so there's, additional, within the skilled facilities, there's activities and social work and other people that can assist them in making the transition. Home health services. So home health services has made a huge impact, right, on our clients. Back when I first became a nurse, um, or 25 plus years ago, Some of the services that we provide for home now, we didn't even think about offering back then, right? A lot of your, chronic conditions, even acute conditions, can be treated at home with, the necessary equipment and tools that your patients may need. Um, and so, they could do skilled care nursing at home. They can do PT, OT, speech. There's also, CNAs or home health aides that can go into the home. It really just kind of depends. And so home health can be public or they can be private. Of course, they are always supervised by a licensed professional as well. So there's, a variety. There's, individual home health companies, the hospital systems may also have their own home health company, right, to provide services once the patient is discharged from the hospital. But one of the differences between home health and say long-term care's rehab facility is that it is focused on not just the client's environment, but the needs of the family as well. And so the purpose of home health is to promote, maintain, or restore health. And then minimize the effects of the illness or disability. So that is why we provide for all of these different services within the home. Your skilled services, whatever the skilled service or whatever the skilled need of the patient is going to be provided and directed by the registered nurse. And then the LPN or the LVN will do the basic nursing services right under the um, supervision of the RN. But that's where again your Nurse Practice Act is going to come into play. So depending on what the state says, or even your the agency that you're working for, LPNs can provide a lot of care within the home health care setting. And they will have a plan of care, right? Um, and so, often we'll have team meetings with the RN, the LPN, and the unlicensed personnel. Anybody working in home health now? No. I don't know if I can do home health. I've thought about it, but I just don't think I can. I don't I don't like going in. I just don't like going into other people's houses. I feel like I'm invading their space, their privacy. I don't know. Um, but here, some of the things teaching, supervising, administering or preparing medications, injections, glucose monitoring, also assessing the safety of the client's home is going to be key as well, right? What can we do to make their environment safer? We can do wound care, ostomy care, bowel bladder retraining, oxygen therapy, right? So a lot of the same services that can be offered within the hospital or in a long-term care, rehab facility can be offered at home as well. Said that already. And then other types of care, community health nursing services, right? Talked about that in community, right? The major focus of community health is improving the health status of communities or groups of people, right? Through education, early screening for disease, and then of course, providing care outside of the acute care setting. And so again, it's, prevention, modification of health issues. Um, and we have daycare centers. Um, adult daycare centers, um, these are they're both hospital based as well as freestanding. And this, provides, supervision based, because of physical or safety needs that are not nursing home candidates. It may be that they have family members that are there in the evenings to help them, but maybe they don't have anybody during the day because those family members are working or in school, whatever. Um, so we have adult daycare services. So this is like PACE. So they, it's in a lot of situations or a lot of cases, they'll have like a bus or a van that will come pick them up in the morning, bring them to the facility. They stay there for the day and then they are taken home in the evenings. Um, and it's, a lot of times it's often just about socialization, right? For one, they're not sitting home by themselves all day. It also provides stimulation. They will get some assistance with their ADLs. Of course, a nice, safe environment for them to be during the day. Um, and so they also get meals, which is a plus, right? So they don't have to worry about packing a lunch, doing things like that. Um, and a lot of times, in some I've actually seen where they'll have providers on site as well. So, they go during the day, they may actually have a healthcare provider that is there in addition to nursing staff, right? So if there is an issue or a concern, they are able to see a provider. Um, a lot of times too, they offer like transportation. If there are providers outside of that area, they can go to their provider. So there's a variety of services. They have social workers on site as well as CNAs. Um, and in some, they actually will have volunteers that will go in as well. Independent living. Again, these are just facilities that, may just be like senior apartment complexes, that kind of thing. They, just kind of are in a safe, independent living apartment. Your assisted living is a home with services. They're usually, older adults that want to try to stay as independent as possible, but may not be able to, perform all of their ADLs, right? They may need some assistance with ADLs. They usually have private rooms or little apartments. Um, they're usually handicapped accessible as well. And then they do have help with daily routine, but they usually don't have like 24-hour care. Um, and so um, some of these assisted living facilities are super expensive and offer, a wide variety. It just really depends on the type of facility that you're looking at. Whether you're looking at independent or assisted living, some of the communities have like all levels, which I think is really cool. They'll have like the independent living, they have assisted living, and then they have like a long-term care and skilled care. So like, if the patient declines, right, they don't have to go far. They, just move from one level of care to the next. Um, Residential care homes with occasional mild cognitive or mobility are also available. We also have continuing care requirement, not the continuing care retirement community. And that's what I was saying, right? They can start and they can, what if they fall and break a hip, right? They can go for skilled care services and then they can go back into their apartment, right? So it's kind of all inclusive, which is nice for some. Um, and then we have our rehab services. This rehab services, they try to get us back to previous highest level of functioning possible, right? As close to the previous level of functioning possible. There's, rehab centers, there's long-term care, there's outpatient, there's residential homes, clients home, where rehab services can be provided. The focus again is just a return of function, prevent further disability. Oops. Your wellness centers. And so they promote wellness, try to detect diseases in early stages. They do nutritional counseling, exercise programs, stress reduction, weight control. It is mostly private, um, but Weight Watchers, your smoking cessation, um, stress reduction. Everybody needs stress reduction at some point in their life, right? Um, what else? Parenting classes, weight control. And so a lot of times too, these are going to, be all incorporated, and nurses can also play a huge part in the wellness centers. And then we have our hospice care. So hospice is your end of life services that is available to those that have been, diagnosed with a terminally ill condition. For adults, right? They generally will have 6 months or less to live. Um, and so hospice is to maintain comfort, right? As the main or philosophy is to maintain comfort as death approaches, right? Dying with dignity. Um, and hospice can be offered in a variety of settings as well. It can be offered in the hospital, it can be offered at home. There's hospice centers or like hospice homes. Um, long-term care, they say long-term care. So it can be offered in a variety of settings. Um, and in um I forgot what I was going to say. That's all right. Um, and it's still going to be a whole healthcare team that is going to be involved in these patients' care. So RNs, LPNs, nursing assistants, social work. Um, they also may have chaplain, right? That is involved in the care with the patient as well. Home health aides, just a variety of different services. Palliative care is similar to hospice care. It does provide comfort care. Um, it is usually instituted at the onset of treatment, and may not have um, so with palliative care, they may not be hospice, right? Hospice patients will receive palliative care, but not all palliative care patients are hospice patients, if that makes sense. In some cases, whether it's, these patients can receive palliative care even if they're not terminal. Okay, so that's the difference. So they don't have to be, can get palliative care without being terminal. What else? Um, and so the goal with palliative care is to improve quality of life, not just for the patient, but their families as well. It's, about relieving symptoms, um, stress. They are able, during with palliative care, they can choose life-saving treatments. With palliative care, unlike with hospice care, right? We usually are not doing any of those life-saving treatments anymore. Um, and so they were to relieve, the symptoms of the loss of appetite, the pain, the nausea. They also help, making those healthcare decisions, as well as supporting your family members, right? So sometimes it's not always about palliative care, but it's also for like things like respite care too. Has anybody heard of respite care before? So respite care can be provided at home. It can be provided in a facility. It really just depends on a lot of times what insurance is going to recover or to cover, not recover. Um, and so, like, when I worked in long-term care, we would sometimes get respite patients, whether it was for a weekend, whether it was for a week. And it's really just kind of to take, a little bit off the family. In some cases too, like we've had respite care because the family was going on a vacation, or, we had one where, the patient was hospice, they were declining rather quickly. And for whatever reason, even though they were providing the hospice care at home initially, for whatever reason, they did not want the family member to pass in the home, which in some cases, I mean, that's completely up to them and the patient, right? And so as they were beginning to transition, they brought them in for respite care. And they were there, I think it was like 3 or 4 days before she passed away when she came in. And I remember I was working an overnight shift, and when I took their last set of vital signs right before the next shift was coming on, and she had respirations of 3. So she was only breathing 30 times per minute. And I was for sure, like when I came back, though, she was not going to be there that evening when I came back to work at 10, and she was still there. She made it until she passed. Probably, I was like around 2 o'clock in the morning, is when she passed. Her whole family was there. And so I just thought I don't know. Like to this day, I don't know how she was even sustaining on her respirations of 3 per minute. But she did. She made it a whole other 24 hours, which I was very surprised at. So, all right. Any questions on chapter 15? Everybody's good? All right. So let's go ahead and take a break. Be back at 3:55. All right. So chapter 16, um, this is all about healthcare systems, financing. So we'll talk about, financing of healthcare costs. We'll talk about the Affordable Care Act, the different types of payment options, funding, and of course, the LPN's role. Um, so I will share my screen. Um, okay, sorry. All right. All right. So the US healthcare system oh, has definitely been described as poorly organized and complicated, maze of services, which lacks preventative care, waste resources, and is very expensive. Um, and so I'm sure everybody has heard that or experienced that themselves, while as a patient or a consumer of healthcare services. And there's a long history there as well. Um, and so Medicare changed from fee for service to what's called a prospective payment based off of DRGs, which are diagnostic related groups. And then other insurances followed. Um, and so that payment system extended to include our healthcare provider payments, which led to managed care organizations. Um, and so how do I explain it? Your managed care organizations, those are like your HMOs, your PPOs, your POS, depending on what type of, insurance that you have. Um, is kind of, some will fall under the point of service plans, or preferred provider organizations, depending on what type of insurance your employer offers, or um, if it's an outside provider. And DRG is a diagnostic related group. And so what that means is, um, they got paid a certain amount of money for a specific disease, right? So if they got admitted for, congestive heart failure, that kind of thing, the goal with that is that the providers within the hospitals were trying to minimize the length of stay. And so, basically just providing as much care within a minimal length of stay, which mean that the hospital would make more money off of that patient, right? Just by, trying to get them in and trying to get them out. Um, and so again, we have all these other different types of payment systems. It really just kind of depends on, what your employee, like I said, what your employer offers, that kind of thing. Um, and even with all of these changes that occurred, we do know that there was, for one, there's still a number of people out there, right, that, don't have access to healthcare. And so we did have a small improvement in healthcare costs. However, we do know that there's still a whole lot of inequities and inequalities, um, depending on, what is going on with that patient. So I already said that. And then we had our Affordable Care Act with our healthcare reform. And so healthcare reform, this was back in 2010, right? We used to call this Obamacare. It was signed into a law by President Obama, hence that's why it got the nickname Obamacare. But it was the first sweeping piece of legislation to address healthcare reform since 1965. So that's a pretty significant amount of time. Um, and the goal was, right, to enhance the access as well as the affordability of healthcare, right, to everybody, in need in the United States. It has significantly decreased the number of uninsured people in the US. However, we still do have a lot of people that are uninsured. It also eliminated lifetime coverage limits. It also reduced drug costs for Medicare beneficiaries. And also, I don't, and y'all are a lot younger, but there was also a big issue too with pre-existing conditions, right? If you had to change insurances, and you had a pre-existing condition, a lot of times there was some sort of a waiting period for services. In some cases, you were denied insurance because of pre-existing conditions. And so this did help to do away with that. Um, the Affordable Care Act established a health insurance marketplace. And so this is a pretty good resource for people, families, small businesses, to just learn about health coverage options. Um, Choose a plan, enroll in coverage. It also gives information that how people with low to moderate income and resources pay for services or pay for coverage. So it did open the door for a lot of people to get health insurance. And then back in 2017, that is when the Affordable Health Care Act was approved. And that kind of replaced, or I'm sorry, the American Health Care Act was approved, and that replaced the Affordable Health Care Act. Sorry. But it was never enacted. So that's always great, right? Um, but I don't know if anybody is, under the Affordable Care Act, if anybody is able to get insurance through that. They did initiate a penalty, right? So that if you did not sign up for the insurance, come your tax rate, then you incurred a penalty on your taxes. So when we look at financing, the two most common ways are to pay or finance healthcare services is your fee for service and your capitation. And so fee for service is the traditional method of paying healthcare bills, right? The physicians are paid a fee for whatever services they provide, and those providers are directly reimbursed. For most order diagnostic tests and treatments for illnesses. Some will not reimburse for preventative or diagnostic tests for early stage illnesses. So you go to the doctor, right? And you get your physical, or you're sick, you go to the doctor, right? And then the doctors are directly reimbursed for whatever services that are provided. With capitation, that healthcare's providers receive a fee per member over a designated time frame. So those healthcare providers will get a set monthly fee for a specific set of services. And if there's any costs that are above that set fee, then the provider absorbs the cost. The goal is to keep the members healthy, right? So that helps to, increase the profit for the provider. So if they're getting, let's say they're getting, $500 a month for, let's say 20 patients, right? But if those 20 patients are not receiving services every month, right, then that's just money that the providers are making. So when we look at how clients pay for healthcare service or how we pay for our healthcare services, right, there's personal payment. That's your private pay, right? You make a doctor's appointment, you get seen, whatever, and then you pay the provider out of pocket for whatever costs were incurred, right? And so this can get very costly, right, if you don't have health insurance. This was the primary method before the 1940s, right? So you went to the doctor, you had to pay for whatever services. Cost of healthcare services discourages this, right? You never know. You go to the hospital, you know, or to a provider, you really never know exactly how much it's going to cost, right? Until you get that bill. Private health insurance, right? This, um, pools individual contributions for a common group goal, right? So it helps you to reduce your healthcare costs, although even sometimes private health insurance can be very expensive. But it is offered by most employers, within the United States. Um, and it depends on the employer as to how much they are going to contribute to your health insurance. Some employers, will pay a big chunk of your premium, while other employers will pay a smaller part of the premium, or in some cases, no part of the premium. Then it's completely up to the employee. It really just depends. The Affordable Care Act prohibits discriminating against people with pre-existing conditions. So insurance companies are prohibited from refusing coverage to anyone based on their medical history or their health status. It also prohibits individual and group health plans from placing lifetime limits on the dollar value of coverage. It also prohibits the insurance companies from rescinding coverage, right? So let's say um, you have private health insurance and somebody is diagnosed with cancer and now they have to undergo cancer treatment, right? They can't just turn around and rescind coverage, right? Just because someone was diagnosed with cancer and needs to get treatment. Private individual, which is your non-group health insurance. This is offered by insurance companies to individuals who are not part of a group, right? So you're not employed, or your employer doesn't offer any kind of health insurance, then this is going to be your non-group health insurance. Um, and so this is something too, because prior to the Affordable Care Act, a lot of people couldn't afford health insurance, right? It's super expensive. And so one of the things that the Affordable Care Act has done has improved access. Um, and so generally it is some sort of a middleman or third party coverage. Um, the Affordable Care Act does not require all employers to provide health benefits, but it does impose penalties on large employers. So if they have 50 or more employees and don't provide their insurance, then there's going to be penalties for that organization. Um, and it also, can't provide coverage that is unaffordable. So there is that. The smaller businesses, like the ones that are 50 employees or less, they will actually receive a tax credit if they offer health insurance. We look at health insurance terms, and then sometimes I get these mixed up myself, especially when it's that time of the year when you have to do your annual update, or is that open enrollment? Um, so premium is the fee that you pay for your health insurance coverage. Again, this is like the set fee, usually a monthly fee that you have to pay. If you have insurance through an employer, this is where I said sometimes the employer will pay a big part of your premium. Sometimes they only pay a small part of your premium. It really just depends on your employer. Your deductible is the amount that you must spend out of pocket for healthcare services before the policy will begin to pay its share. And so when you're choosing health insurance, those are the two things that I always look at, is going to be how much do I have to pay every month, right, for my insurance? And then how much of a deductible do I have to pay before my insurance actually will kick in and start covering things? Um, And so that's really important, right? Because if you have a high deductible, but you don't use the doctor very often, right, then you're paying more out of pocket than and as well as, what your premium is. So it's kind of just like when you're shopping for car insurance, right? You get to kind of choose your deductible, and that will kind of give you an idea what your payment's going to be like for your car insurance. Um, your copay. That is the amount that you pay at the time of the visit, right? Your prescription, your hospital service, whatever it is, right? Most people will have, they may have a specific copay for primary care. They may have a different copay for a specialist appointment, another different copay for radiology or labs, another for hospital services, right? So this is something else too that you need to look at. Um, and then co-insurance. Once a deductible is met, the percentage of the total bill the insured person must pay. The insurance company pays the remainder. So you meet your deductible, and then you go to the doctor, and let's say it's $500. Okay, but your insurance is only going to cover 350 of that. That means you still owe another 150, right? So another, kind of have to look at all of these things when you're trying to pick your insurance plan. There was something else I wanted. And then of course, some people may be fortunate enough, right, to have two health insurances, and that makes it a little bit easier because this would apply to the primary, and then your secondary insurance usually will pick up anything that's not covered by your primary. So it does kind of help with our public health insurances. This is, of course, your Medicare, your Medicaid, and your Veterans Health Administration. So the Veterans Health Administration, right, works with our veterans, hospitals, outpatient clinics, nursing homes, domiciliaries. They offer, pharmacy, I use the VA for my VA disability. And depending on where you go, what area you're in is going to really determine what your VA services are, what VA services are available. So it really kind of just depends. With Medicare, this Medicare was initiated in 1965. Medicare was added to the Social Security Act. It is a federally sponsored program. I guess I should switch my screen. And public health insurance plan for patients that are people that are over 65, as well as their spouses who have at least 10-year record in Medicare covered employment and are a citizen or permanent resident of the United States. So in order to receive Medicare, you have to pay in for at least 10 years. Coverage is also given to certain younger persons with disabilities and those that have ESRD or end-stage renal disease. Nobody is denied coverage based on past medical history. So once you hit 65, right, you are eligible for Medicare. And so think of, our elderly population that is ever growing. There's huge demands right now on Social Security as well as Medicare, just because of those wonderful aging baby boomers. And before you say it, no, I'm not a baby boomer. I am just past baby boomer, so I am Gen X. Medicare plans, we have Part A, which is your hospital insurance. So this is going to cover any of your inpatient hospital stays. If you need to go to a skilled nursing facility for rehab, hospice care, as well as some home health care. Part B that is more like your physician services, outpatient care, your diagnostic tests. Um, the Medicare Part C is the uh, Medicare Advantage plan. This is offered through private insurances that will contract with Medicare. This can be your HMOs, your PPOs, your fee for service, right? All different types of plans. Also offer prescription drug coverage. So I don't know if anybody has like seen the commercials. Usually, when I say like Medicare enrollments, usually like they start to ramp up in like November. They start showing the commercials, like if you're eligible for Medicare, and they'll start to have like all these commercials for the Advantage plans. Um, and those are going to like, so Medicare Part A and is free, right? Nobody has to pay for that because you paid for it for 10 years. Your Part P, your Part C, those are things that you would have to pay out of pocket for. And so a lot of people don't understand that. That it's just additional money that they have to spend. Um, your Medicare Part D, that is your prescription medications. So the Medicare, what is it? Medicare drug legislation was passed in 2003 that provided prescription drug coverage to help pay for brand name medications at certain pharmacies. It's also offered by insurance companies and other private companies that are approved by Medicare as well. Um, so it is, it really just kind of depends on as you get older, kind of like what your needs are. But like with the hospital insurance, it will cover the meals, the meds, any of the supplies, the tests, ICU. Um, it will for what do you call it, for if you have to go to a skilled nursing facility, it will cover about 20 days. um and then if you have to stay longer, because like I said earlier, right, a lot of times it's up to 100 days. Then there is going to be some sort of a copay or co-insurance that the patient will have to pay if they need to stay longer. And so it won't cover like long-term care at all with Medicare Part A. Part B, your healthcare provider visits, your outpatient hospital services, even if you go to the emergency room, it's going to be covered under Part B. Mental health, your labs, your X-ray, your radiology, if you need transportation, so you have to call 911, an ambulance has to come get you, durable medical equipment, and then for our kidney patients, it's going to cover the supplies and services. Part B will cover some of the diabetic supplies as well, PT, OT, speech, trying to think. Um, the preventative services are all going to be covered under Part B. So, I mean, there's, a lot of services. Part B will not cover medications, um, dental care, hearing aids, that glasses, that kind of thing. So that's still another need that these patients will have. Medigap insurance, um, a lot of times it's purchased to cover Medicaid things Medicare doesn't cover. So your deductibles, your co-payments, your co-insurance. Patients cannot enroll in both Part C and Part D. If you have a Medicare Advantage plan, which is your Part C that includes prescription coverage, and you join a Medicare prescription plan D, then you'll be unenrolled from C. I know it's kind of it's interesting. Um, and then we have Medicaid. So Medicaid was added to the Social Security Act back in 1965, and it provides medical assistance for eligible families and those with low income. And so it is funded by both federal and state. right? So it gets money from the federal government, but each state also kind of runs its own Medicaid program. Um, and so the federal government establishes those broad national guidelines for Medicaid, but each state will establish its own program services and requirements, including eligibility. So that's like if you're going from state to state, you might be eligible for Medicaid in one state, but not eligible in, you move to another state, you may not be eligible for Medicaid in that state. So like I said, even though overall it's federal, but each state has its own requirements. Um, and then under the Affordable Care Act, Medicaid improvements, CMS, which is the Center for Medicare and Medicaid Services, um, works with the states to base their Medicaid and Children's Health Insurance Program, which is the CHIP program. And then there's also uniform Medicaid eligibility and income definition across all states. So that kind of got rid of, the prohibition that prevented states from providing Medicaid to adults without dependent children. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. So they have to be here for at least 5 years in order to be eligible for Medicaid. Any questions on the difference between Medicare and Medicaid? Because I know sometimes it can get a little confusing. So again, Medicare is for those that are 65 years and older, that are eligible for Social Security, some younger people with disabilities, and then your patients that have end-stage renal disease. Whereas with Medicaid, that is for those that have, low or more low socioeconomic status with that decreased income. And so again, Medicare is going to be administered by the federal government. Medicaid is variable, right? It's overarching is federal, but the states implement their own Medicaid plans. There is a cost with Medicare for the recipients. With Medicaid, there is no fee, but the person has to meet the income eligibility requirements in order to get Medicaid. Does that make sense? I just want to make sure everybody. So, and then we have SHIP, which is the Children's Health Insurance Program. This is another great program. It is under Medicaid and it provides medical assistance for eligible children. And so it covers and insured kids up to a, specific income guidelines. So they get free or they get low cost insurance for children up to age 19. So again, still does have some income requirements, right? But this one is primarily for our kids. So we look at cost of health insurance. How many of y'all just raise your hand if you have insurance through a family member or your employer? Okay. So depending on, depending on the employer, right? Or that's usually, going to determine how much you're paying out of pocket for your premiums, your co-insurances. Some insurances are better than others. I will tell you, I have been very fortunate. My husband and I are both, well, I'm prior military. My husband is retired military. So we are, yeah, good old military benefits. Yep. Those military benefits, they can be difficult to maneuver sometimes, not going to lie, depending on which type you have. But at the same time, it is good that we have insurance. And so with him retiring, we chose TRICARE Standard. So we had a little bit more, did have, some more out-of-pocket costs with TRICARE Standard than with TRICARE Prime, but we are both also still working. So we have, other insurance so that is just kind of picks up the extra for us. And then of course, when we hit 65, we are still eligible for benefits. So that's one thing that is nice. But it's crazy how much health insurance costs. Um, I have one friend whose son was paying a $900 premium every month for his healthcare insurance. And that was through the Affordable Healthcare Act. $900 a month. And that, again, that was just his premium. That wasn't his co-insurance. So it wasn't his deductible, right? And so it's seriously, I still think that we still need to do something with the system because it is still crazy expensive. And so continual rise in healthcare costs has resulted in annual increases in health insurance premiums, right? And so a lot of your providers are your employers. I mean, they will kind of go through and they will try to find um, what the best option is for the company and their employees based off of the cost of insurance. The Affordable Care Act requires the federal government to create a process in conjunction with states where insurers have to justify unreasonable premium increases. I'm not quite sure what unreasonable premium increase is. However, yeah, at least they have to provide a reason for it. When we look at the uninsured, um, and so again, we still have quite a lot of people in the United States that are uninsured. The uninsured often affects your low wage employees, right? That are in the lower wage jobs that are less likely to offer insurance benefits, as well as the middle class. Middle class, some of the workers are unemployed. And then those employed, workers are priced out of the healthcare insurance because of the rising premiums, right? So I don't, again, kind of just depends on where you work and what insurance is provided, is going to be just, that's going to determine the premium. In 2014, as a result of the Affordable Care Act, citizens and residents were required to obtain health insurance or pay a penalty. That's kind of what I was saying earlier, right? But then in 2017, they did away with that, right, as of 2019. So, I mean, that's one thing. But like I was saying, my friend's son who was paying who would have had to pay $900 a premium every month, he opted out and decided just not to have health insurance. He said because even the penalty at the end of the year was going to be less than what he would have had to pay every month for a premium. And I was like, that's insane. Part of it, which I always thought this was interesting, and just as a side note, so, we talked about pre-existing conditions, right? And they can't deny you for pre-existing conditions. He was actually, he was a cancer survivor. He actually developed cancer when he was in high school, had been cancer-free for 10 years at this point. And just because of his history, that's why his premiums were so high. They didn't deny him, right? They did not deny his coverage, but they definitely, increased his premium because of it. Um, so it's just interesting. And so, it's just, these are things that people have to kind of look at. When we look at, alternatives to pay for healthcare, Medicaid, if they qualify, right? That is an option for people, again, low income, right? If they can afford, then they will, pay out of pocket. Charity, some will actually face medical bankruptcy. So this is a huge issue too. And then think about it, the underinsured, the uninsured, in emergency situations, right? They may go to the hospital because they need services. And then, they're not able to pay for those services. Even though they will try to recoup that money from the person, right? The hospital in those cases end up eating the cost of providing those services, which then leads to the hospitals increasing their fees, right? So it's a vicious cycle all the way around. Um, Lack of access to healthcare prevents individuals from receiving their preventative care, treatment when they are, developing a health issue, which results in a delay of care. And think about that too. And how many times are we going to tell our patients, right, when we're providing education, right, about preventative care, right? The goal is to prevent treatment or, to prevent illness. So we want them to get those preventative services, right? But if they don't have access to healthcare and they don't have insurance, are they going to go get that preventative care? And then they have an emergency or something happens, and then we have these things that are being diagnosed in the later stages, right, which makes cure less likely, right? It's more debilitating. And just like with the urgent cares, a lot of people rely on the emergency departments for all level of care, and that's again because they don't have insurance, they don't have access to a primary provider. Hold on. Perspective, sorry, I had to fuss at my dog. Prospective payment system. Um, this is with the prospective payment system, this is a reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide the care. So I'm trying to think, let's say somebody goes in for diabetic ketoacidosis, okay, and they are going to get a set amount, right, through a prospective payment system to provide care for diabetic ketoacidosis. All right. If the amount that it costs is more than what the PPS is paying, then the hospitals are not getting reimbursed for that. They're just getting reimbursed from what the insurance says. And so it's based off of, right, those DRGs that I was talking about earlier. And so if you ever notice, I don't know how many notice, like when you go to, um, you know, um, look at, say you need to go to a specialist, you have a list of in-network and you have a list of out-of-network providers, right? In-network providers have generally agreed, right, to whatever the payment is, whereas out-of-network is like, no, we don't agree with that, but we'll be an out-of-network provider. So that's kind of, what it is. And so it does, kind of, encourage those hospitals, right, to control their costs. And, a lot of times too, though, if we think about it, right, this is, where we're discharging maybe a little bit too soon, right, as a way to try to reduce costs. Again, here's your DRGs. And so this was an attempt to, stop the cost, the skyrocketing cost of healthcare. And so it's a formula to, basically figure out how much the government is going to pay for the hospitalizations, and hospitals are told in advance how much they are going to get. And again, they are going to get a flat fee regardless of the length of stay. Quality, safety, cost of healthcare. Improving quality in healthcare is one of the biggest things. This is where your CQI comes into play, which is your continuous quality improvement. This is inspecting, client incidences of harm or mistakes after they had occurred, but we're looking at preventing mistakes. Has anybody worked in an organization that has a quality improvement department? No. So one of the things, depending on where you work, you may ask to be, you may sit on a quality improvement um, committee to try to focus on ways to, prevent problems or adverse events. A lot of times too, we'll look at past, like what's happened and ways that we can, to try to prevent those things from happening. It is the aim of the Institute of Medicine for improving quality in healthcare. Has anybody heard of, just out of curiosity, has anybody ever heard of the report To Err is Human? So To Err is Human came out in 1999. I know it's a really long time ago. And it found that up to 98,000 people died each year from preventable medical errors. And it wasn't just like it was wrong site surgeries, it was other things. It's, of course, medication errors are also in there. And so To Err is Human, they published this back in 1999. They've done two follow-ups since then. One was in 2019. I don't remember when the other one is. I apologize for that. But basically in that 20-year span, there was not a significant improvement in the number of deaths or injuries because of medical errors. So this is where your Institute of Medicine is really pushing to improve quality in healthcare. And this is some of the things like where we do like when someone's going into surgery, we do a timeout and we do a double check, right? Make sure that we got the right patient, the right site, all of those things to try to prevent medical errors from occurring. It also makes sure that we have continued competency and continuing education as well as certification. Improving safety in healthcare. Um, and so with the improving of safety in healthcare, we have the Joint Commission on National Patient Safety Goals. And I'm sure everybody has heard of the NPSGs, or at least I hope everybody has heard of the NPSGs. And so we know as nurses, right, we've always, right, tried to push, promoted safety. That's one thing that you've, learned in nursing school, right? Is that safety is key. And so one of the things that the Joint Commission does do is it reviews adverse incidents and causes of serious harm as well as death to patients. And so, they came out with the National Patient Safety Goals. What is it? Every 10 years, they produce another list. So if you've not looked at the National Patient Safety Goals, just take a look at them. They cover every aspect of healthcare from birth to death. The National Patient Safety Foundation works with the Institute for healthcare improvement. And it's just building systems of safety across the continuum of care. They work with, clients, they work with families, they work with the community to improve client safety. And then we have our transition to practice. And I think this is one of the better things that I think is really cool. Better than like, what were they called? They were called like preceptor programs when you entered into a hospital. The transition to practice, again, this is aimed at improving quality and safety of healthcare by new graduates as you guys are transitioning into the workforce. And so there is a transition to practice model. It's anywhere between 9 and 12 months. So it's actually really it's a really cool thing. If you think about it, right? When you go, depending on where you're going to go work when you graduate, right? That's kind of determine what your orientation process is. Um, Before the transition to practice model, it really was more like a residency program. You worked on projects and things like that, where the transition to practice really focuses on how you can transition from that student into the nursing workforce. And so it's actually a really interesting program. And then, of course, improving the cost of healthcare. So cost containment is huge. Um, and so one of, the basic, is trying to contain costs, right? Reducing waste, reducing inefficiency. So we need to be really mindful of that. Making sure that, when you're providing care, that you're following policy for charging the clients for supplies, that you're following policy for documenting care for reimbursement. And this is where documentation is so important, especially, for the care that you are providing. Who are my CNAs now? Who are, who are you? Yeah, who's a C? Okay. So, it's just like when you do your daily documentation, right? On ADLs, on feeding, making sure that it is accurate is key, right? To making sure that, whoever that, insurance provider, whoever is covering the cost of their care knows that the care that the patient is being or is receiving, making sure that you're efficient in delivering your care, trying to prevent those complications so that the cost or the length of stay isn't extended. Um, and so it's just really interesting if you ever get to sit on a CQI committee. It's really just the interesting process. When we look at quality improvement and payments and penalties, pay for performance and never events. And so these are two that we have to look at. Pay for performance. So with all of the changes in healthcare, there's been a huge push for quality versus quantity of care, right? You can go in and make sure that everything is done for your patient, right? But if the patient's not satisfied, right, then we still did something wrong. And so pay for performance, which is your P4P, rewards hospitals for meeting and exceeding standards of care for a variety of diseases. Um, have you guys heard the term never events before? Anybody heard the term never events before? Um, so never events are seriously and highly preventable events. So this could be a hospital acquired infection, like a central line infection, a catheter associated urinary tract infection, your ventilator assisted pneumonia, those kinds of things. It also could even be the development of a pressure area. And hospitals will not receive reimbursement for never events. So this is why we need to be very careful when we're caring for patients. Um, when we have a patient in our care and they have a Foley catheter and they develop a CAUTI, right? The hospital is not going to receive reimbursement for treating that CAUTI. So it's why there are so many policies and procedures that are in place, right, to try to prevent that from happening. So something just to keep in the back of your mind. Another thing too that they're trying to do, which this is always going to be an issue, is the readmissions. Um, so we talked about cost and cost containment, right? And the goal is to provide the quality of care, the least amount of, cost out of, over cost. But we try to get them out of the hospital, right, sooner than later, right? And that's the big part of it. They will get, if they have a patient that is discharged and is returned within 30 days and returns to be readmitted within 30 days, then they will get a reduced payment. All right. So let's say you had that same diabetic ketoacidotic patient, right? That we stabilized and we discharged, okay, and they come back within 30 days, then that hospital is going to get a reduced payment for that second hospitalization. So that's why it's super important that we are making sure that we are doing everything possible. Hospitals have case managers as well. Some of them will follow them once they are discharged to make sure, right, that they are, being compliant, that they're checking your blood sugars, right, whatever it is that they need to do. And so these are like your MIs, your heart failure, COPD, your surgeries. And so this is where that transitional care is super important. Nursing actions for quality improvement. So the aims of the Institute of Medicine, kind of covered some of this already, but we'll go through. So avoid injuries to clients, right? That's number one. Try to avoid those injuries, making sure that they are safe. Reduce waits, sometimes harmful delays for those who receive and those who give care. um, Provide services based on scientific knowledge to all who can benefit, avoid waste of equipment, supplies, energy, right? Provide care that does not vary in quality because of personal characteristics, and then care that is respectful and responsive to individual care preferences. I talked about those. So the national patient safety goals for long-term care, improve the accuracy of resident identification, improve the safety of using medications, reduce healthcare associated infections, reduce the risk of resident harm resulting from falls, and then of course, prevent healthcare associated pressure air ulcers. And so just that kind of just speaks for itself. With the hospital, again, 2 patients identifiers, improve effectiveness of communication, improve safety of medication, reduce harm, reduce risks of healthcare associated infections, identify safety risks, universal protocol for preventing wrong site, wrong procedure, wrong person surgery. So somebody asked for a break. So I'll go ahead and take a break, be back at 5, and then we'll finish up these slides and be done. All right. So as an LPN, what are the roles in cost containment? So I talked about these, right? Follow your policy for charging clients and documenting care. Um, Make sure that you're organizing your care for effective and efficient use of your time. This is like, if you're going in to do a treatment, make sure that you have everything you need, right, prior to going into the room, and don't bring a whole lot of extra. Um, Once you bring something into that client's room, you can't reuse it when you can't take it back out, right? It has to be used for that client or that patient. So that's part of it as well. Um, be efficient and effective in delivering care. If some aspect of care needs to be redone, it means you could have done it right the first time. And we understand that mistakes happen and things happen too, but always try to make sure that you're, very efficient in what you're doing. Um, Making sure that you're, part of that implementing care to help prevent complications. Um, and talked about some of those, like your caudis, your central line infections, your excuse me, your pressure areas, making sure that you're providing client-centered, relationship-centered care. um, and so last part of this is restructuring of the healthcare system. So changes in healthcare to improve delivery of care, increase the quality and safety of care, decrease cost. Um, and that's the restructuring part. And it's a response to the rising costs. And so there's what we call alliances, which are partnerships from, among hospitals, clinics, labs, healthcare systems, healthcare providers. And so they network to coordinate delivery or care delivery and contain costs. So like, even buying supplies in bulk, right? Um, and then, mergers and acquisitions. And so again, this is, larger healthcare systems, acquire smaller systems. And so larger systems can negotiate. They have a greater power for negotiation than some of those smaller systems do. And then, consolidated systems of healthcare. And so those are include hospital systems found nationwide. Um, and dealing with change. And so change is something that is going to occur all the time in healthcare. Um, and so there's different ways to look at it. And so are you a victim? Are you a survivor? Or are you a navigator? So victims look at change in a negative way. Of course, the worst is going to happen, right? Because of the change. And they often feel helpless. They are not going to participate willingly in the change, which then the change is going to overcome them. Um, Survivors resist change but go along for the ride. They claim the change will never work. Um, and so, but they will go along for the ride. Where's your navigators? They feel control of the situation. They're confident and excited about the possibility of being part of a solution. They have some control over change rather than being controlled by the change. So everybody looks at change differently, right? It's really kind of how you want to view it and how your experiences with change in the past generally is going to influence your ability to deal with change in the future. But one thing that I will tell you with, like I said, in healthcare, change is one thing that you can always rely on happening. It's just something, that we do have to kind of get used to, as you are working in healthcare. And so last part, you need to present yourself as invaluable to the healthcare agency. And as an LPN, right, be self-directed, be motivated, be a problem solver. Don't be part of the problem, right? Identify what needs to be done and do it. Collaborate, of course, if you need to. Respond flexibly to changes, identify tasks or protocols that could be done more efficiently, use your good critical thinking skills, and be a role model. Um, and so with that, just think of, your experiences that you've had, whether you're working in healthcare now or even if you're not working in healthcare, we have all been part of a team that is maybe dysfunctional, right? And maybe we've all, some of us have been part of a team that has been absolutely fantastic, right? Um, at the same time, too, think about, some of the nurses that you have seen when you have been out in clinical. And I'm sure there's been a variety. We may have, I'm sure you've come across the negative Nancy's, and some of the more positive ones. You are the only person that can influence the nurse that you want to be. Okay. That is you, that is your innate self. Um, you can, be that role model for CNAs, for other LPNs, or you can choose to not be that role model, right? It really is up to you. It's the type of nurse that you want to be. Um, and a lot of times we are influenced greatly, right, by who we have worked for and who we have worked with in the past. But this really is your opportunity to really shine. Not everybody is going to get their dream job when they graduate. Okay. And that's something that, may be a little bit more difficult to, um, I guess a little more difficult to swallow than not, right? But whatever position that you are offered and accept, do the best that you can. We talked earlier in the term, right, about networking and, what else? Networking primarily, I guess, right? It's sometimes it's who you know, right? Um, and so if you go in and you shine, right, and you do your job to the best of your abilities, and that's, sometimes going to be what opens the door for you for future opportunities. Um, and so, just go out there and be the best nurses that you know that you can be, that I know that you can be. Um, and, take your experiences, both good and bad, and then turn them into the type of nurse that you want to be. Um, and so, you have patients' lives, right? That you are going to be responsible for. You are going to see patients on their worst days, and you are going to see patients on their best days. And so, how you interact with them, is super important. Regardless if they're the difficult patient or the patient that nobody else wants. Because I'm of my long-term care background, I love the feisty old people, like especially the feisty old women. They are my favorite. Um, the ones that everybody else is like, I can't, she won't take her medication, she won't do this, she won't do that. I'm like, I got it. I'll go in and be with that one. Those are my favorite. And usually it's your dementia ones that get to that point. And so, just this is your time to really, and I'm sure a lot of you have thought about this during your time in school, um, about the type of nurse that you are going to be or that you want to be, because you definitely you're going to make a difference in somebody's lives. And we always want that to be a positive difference, right? We want to develop those therapeutic relationships with our patients' families, right? We also want to make sure that we're building those good relationships with those that we are working with. Um, Other nurses, the doctors, the therapists, the social worker, the dietitian, the housekeeping services, right? Everybody is just as important as the other. Um, and so, I remember, there's always memes or there's always things that you can see, but right, how many people know, the names of the housekeepers? Or the dietary aides, right, that bring the trays to the units. And, it's all a respect. It's all about how we treat each other. And so just really think about that. Um, I remember, and this probably doesn't mean much, but when I was in my RN program, I did, we were at clinicals, we were in the emergency room doing our clinicals, and the nurse that I was paired with, because we ended up doing like a preceptor style for the ER clinicals, um, she couldn't remember my name from Adam. Like, and I had my big old student name badge on, like, nursing student Jennifer Martinez on it. Um, and so she just always kept saying, "Hey student, hey student, hey student," right? Um, she was a great nurse. I learned a lot from her in the 90 hours that I spent with her in clinicals. Um, Still, by the time, she still could not tell you what my name was. And so that really kind of makes you feel, right, some kind of way, like, when you're, interacting with somebody for that long, right, and they still can't remember your name. Um, she remembered my face though, because I remember seeing her at Walmart, like, even this was months later, even after I graduated. And I was just standing, and she goes, "Hey, student." And of course, I turned around and I was like, "You can't remember my name, but you remembered my face." I mean, so I guess it's something. Um, but it's just the simple things like that, right? It's how we interact with people and how we treat people. She was very nice to me. I'm not saying that she was, like I said, I learned a lot from her. It just, the fact that she couldn't remember my name really kind of just bugged me. Um, so anyway. All right. So that is chapters for today. So chapters 15 and chapter 16. Does anybody have any questions? Nope. All right. So I did put the exam reviews on the calendar. Did they show up for you guys? I'm gonna have to check to see if I did not do it. I'm gonna make sure I did it correctly. If it doesn't, I will try again to put them up on the calendar, just as a reminder that they are available. Um, so again, you have a couple options this week to attend, before next Monday. Um, just I want you guys to be as successful as possible. That's all. That is my goal. No, nothing behind it. Just want you guys to finish out these last 3 weeks with a bang so you can graduate and go be nurses. So, all right. Well, if nobody has any questions, that is all I have for today.